Welcome to the Peds NP, Pearls of Pediatric Evidence-Based Practice. I'm your host, Dr. Becky Carson, pediatric nurse practitioner and clinical assistant professor at the Catholic University of America in Washington, D.C. If you're just now joining us, you'll want to go back and listen to episode 75 of the Peds NP Acute Care Faculty Series. In that episode on malnutrition and feeding tube selection, we learn about how to assess for malnutrition, identify patients in need of enteral feeds, and how to select the route to deliver the feeds. If you're all caught up, we'll continue this episode on how to select an enteral formula and start feeds, which was co-written with me by Dr. Marion Malone from the University of Tennessee at Knoxville and Dr. J.D. Murphy from Johns Hopkins University. Let's jump right back into our case on Kyla, an adolescent with anthracycline-induced cardiotoxicity who is ready to begin nasogastric tube feeds to correct her malnutrition. We're going to do another auditory flowchart of questions to ask about formula options so that you can visualize the process of selecting the appropriate formula. Sidebar, I'm not an expert in nutrition, and there are lots of nuanced needs in each individual patient. So these are overall guiding principles, but you should certainly use the resources of your institution to the fullest, especially a registered dietitian or feeding team. Let's get started. At the top of the dietary food chain, ask, is maternal breast milk or donor milk available for infants? If so, this is the nutrition of choice. Breast milk can also be fortified to increase calories, protein, vitamins, and minerals. For older children or those without breast milk options, you're going to ask a series of questions to decide which formula to use. The questions ask about factors like age, underlying medical condition, nutrient requirement, and GI function. All right, let's try it. So when maternal breast milk is not appropriate, let's ask the next questions. What is the age group? Preterm, infant, child, adolescent, or adult? There are choices for each category that support the nutritional needs of each age group. Each formula attempts to mimic what the child would likely take in for their normal diet. Now that you've selected the appropriate age group, we ask our next question. What protein do you want? Protein is an essential macronutrient, and it's essentially the component that differs between formulas. Your protein options are a standard cow's milk protein, soy, semi-elemental, and elemental. Let's break each of these down, pun intended, and I'll give you an example of a commercially available product for each age group. First, there's the classic cow's milk protein, which is generally well tolerated by most people. They contain whole proteins, complex carbohydrates, and long-chain triglycerides. It's complete nutrition. But keep in mind that the nutrients have not been broken down at all, so there is additional work for the GI system to do in order to metabolize them. These are formulas like Enfamil, Good Start, and Similac for infants, Nutrin Junior and Pediasure for children, and Boost for adults. Soy formula is designed for infants with galactosemia, lactose intolerance, cow's milk protein allergy, or those who have cultural preferences that restrict cow's milk proteins. These are formulas like Prosobi, Resource by Nestle, and Ensure. Semi-elemental and elemental formulas contain proteins that have been completely broken down into their simplest form, amino acids. The formula has done much of the work of digestion itself to make it easier to tolerate. You'll remember that detail if you've ever smelled an elemental formula. They don't exactly smell like a milkshake. They're intended for patients allergic to cow's milk and or soy protein, for protein maldigestion or fat malabsorption. These are formulas like Alimentum, Nutramigen, Peptamen Jr., Peptamen, Elecare Jr., and Vivanex. Lastly, we'll touch on blenderized tube feeds. Blenderized tube feeds use blended foods and liquids instead of commercial products. There are some pros and cons to this process because it's way more complex than just dumping your dinner into the blender and hitting frappe. This is a good option for children with allergies or intolerances to the ingredients that are in commercial formulas. But it can be a challenge if that child's ever admitted because food safety issues are difficult for hospitals to accommodate. For example, blenderized tube feeds are only allowed to be hung for about 2 hours. You also need to reevaluate nutritional needs in hospitalized patients on blenderized feeds because their acute illness may require more micro or macronutrients than the prior recipe allows. Registered dietitians play a key role in ensuring that children on blenderized diets are meeting their nutritional needs. Okay, we've gone through the top of the flow chart, maternal breast milk or not, picked a category of formulas based on age, and then picked our protein. The last question I want you to ask is, will a standard formula be sufficient for meeting caloric and fluid needs? In other words, do you need a concentrated, higher density formula? Some infants and children with higher nutritional needs, fluid restriction, or volume intolerance may benefit from concentrated formulas. In that case, you'll choose a concentrated version of your preferred protein formula. These have a number after the name to indicate the calories per ml. So, for example, Peptamen Junior 1.5. Remember that the daily fluid requirement almost always exceeds the caloric content of that volume, especially in children with very low energy requirements. So children may need their formula supplemented with water to assure adequate fluid intake. Just like you need your 8 glasses of water per day, children on enteral feeds also need to make up their fluid needs in the day. All right, now let's practice. Can you help me pick Kyla's formula? Maternal breast milk is not appropriate, so what's her age? She's an adolescent, which means we can use an adult formula. Next, what protein do we want? Well, she's got no intolerances, and her GI system functions well, so I'd say a standard cow's milk formula would be appropriate. We'll pick Boost. Now, let's think about the nutritional needs and fluid. With her current nutritional state and heart failure, I'd say we need a concentrated formula. So Boost Plus at 1.5 cows per ml sounds perfect. Next, we're going to think about how to order the feeds. First, we need to decide on continuous or bolus feeds. Post-pyloric tubes must use continuous feeds. You cannot bolus into the small intestine. Tubes that end in the stomach can use continuous or bolus feeds. Bolus feeds are more physiologic, like a meal, and are ideal for children who can tolerate them. But generally, we need to work toward bolus feeds after tolerating continuous feeds for a while. For Kyla, we should start with continuous. Okay, so how do you start them? The initial rate, interval increase, and goal differs by the age and size of the child. A good rule of thumb is to start at 1 ml per kilo per hour, up to a max of 25 mLs per hour. And then you'll advance by that same volume every 4 to 6 hours, as tolerated, to the final goal based on their total fluid and caloric needs. Big kids usually max out at a rate of around 100 to 150 mLs per hour. Once patients demonstrate the ability to tolerate full volume continuously, the team transitions the regimen to Q3-hour bolus feeds. So, how do you order bolus feeds? Start at a bolus at 3 mLs per kilo per feed for children who are less than 15 kilos, and a general 50 mLs per feed for children who are bigger than 15 kilos. Double the volume every 6 hours to your goal. A typical bolus feed in an older child can be anywhere from 300 to 500 mLs per feed. The duration of the bolus feed depends on how large your tube is, typically anywhere from 10 minutes in G-tubes to 30 minutes for smaller lumens. Let's talk about tolerance or intolerance of feeds. Assess tolerance every 6 hours prior to advancing feeds. Intolerance may present with symptoms such as vomiting, diarrhea, abdominal discomfort, and abdominal distension, with sequential increases in the abdominal girth. Gastric residuals are not good indicators of feeding intolerance, unless they correlate with other signs or symptoms of intolerance. Let's order Kyla's feeds. She's got an NG tube, and we're using Boost Plus. Alongside the unit-registered dietitian, you determine her caloric and fluid goals are 150 mLs per hour. She's an adolescent, so what's your starting rate? Yep, 25 mLs per hour. How much will you advance and how often? That's right, advance by 25 mLs every 6 hours. If she tolerates advancing on that schedule, it'll take us a little under a day and a half to make it to goal feeds. We can plan to transition to bolus feeds once she tolerates goal feeds for a couple of days. Feeding tolerance and nutritional status are monitored frequently, both with symptoms of tolerance, anthropomorphic measurements, and biochemical markers like prealbumin. It's time to wrap up our case study on Kyla. She transitioned to bolus feeds and after a week in the ICU was moved to the floor. After another week, the tube was removed and she started on a regular diet with advice on high-calorie and protein-dense foods. And then she soon went home. This was a lesson that there's more than just formula that goes into tube feedings. It takes a complete clinical knowledge of disease, nutritional assessment, careful consideration of patient needs and illness state, and evaluation of tolerance. The process requires constant reassessment alongside the multidisciplinary team's nutrition experts. I hope that you'll like, comment, and subscribe to the Peds NP, where we discuss the practical application of evidence-based practice in a conversational way that helps you synthesize and transform the best practices from the literature into your clinical bedside skills. Thanks to the acute care PNP faculty who supported the creation and review of this series, especially my episode co-authors, Drs. J.D. Murphy and Marian Malone. You can read all about the contributors and see show notes, references, and competencies at thepedsnp.com/faculty series. Share it with a colleague, pass it along to your classmates, and text it to a friend. There's no financial support or conflict of interest in this episode of the Peds NP. Follow me on Instagram at the Peds NP podcast. Email me at thepedsnp@gmail.com. And remember, this isn't just a podcast. Nutrition is critical to pediatric acute care. I'm Becky Carson. Take care.